Dr. Gocher,
Here.
Dr. Hurt,
Here.
Mayor Jacobs,
Here.
Dr. O'Brien,
Here.
Ms. Roma,
Here.
Dr. Shamia. Oh, I think he is entering the meeting right now. See if that's him. Dr. Shamia, are you here? Yep, you are.
Yep.
Great, we're just taking roll. Dr. Souza,
Here.
Ms. Wagner,
Here.
and Dr. Buchanan.
Present.
All right, looks like everyone is present except for Dr. Drake.
Okay, we have established a quorum, and the next order of business will be approval of the minutes from the meeting of December 16th. These have been sent to you electronically earlier, and in general, if there are no great concerns or additions or deletions to that, we can go ahead and get a motion for approval in a second, and then any final discussion.
Motion to approve.
And a second.
Second.
We have a motion to approve in a second. Any other discussion, questions, additions, or deletions on the minutes from December 16th? If not, Kelsey, if you could go through the roll call for approval of the minutes, please.
All right, Dr. Gocher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Ms. Wagner,
Yes.
and Dr. Buchanan.
Yes.
All right, that is 9 yeses and 1 who is not here.
Okay, thank you. You have approved the minutes. The next item is to set the agenda. And again, the agenda has been published, and you should have a copy of it. Are there any concerns, additions, or corrections to the agenda that we see? If not, we can entertain a motion for approval in a second, and then we can discuss any fine tuning of the agenda that you would like.
Motion to approve.
Second.
Second, we have a motion and a second. Any other discussion on the agenda itself? If not, Kelsey, if you can run through a roll call for the agenda, please.
Absolutely. Once again, this is Kelsey with the Knox County Health Department. Dr. Gocher,
Approve, yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien,
Yes.
Ms. Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Ms. Wagner,
Yes.
and Dr. Buchanan.
Yes.
All right, 9 yeses.
Great, thank you. You have set the agenda. So the next item on our agenda is item 6, which is the Knox County Health Department's benchmark presentation by Dr. Buchanan. So Dr. Buchanan, if you've got your stuff ready, the floor is yours. We're ready to go.
Thank you, Dr. Gocher. So first I'll start as usual with the local situation. We have 129 new confirmed cases since yesterday, 4,901 active cases, 177 Knox County residents are hospitalized currently. And sadly, we have 3 additional deaths, raising our total to 315. And just as a footnote, we are averaging 4 Knox counties passing from COVID-19 a day at this point, which is up from 3 in our previous report. And as always, Dr. Shamia will talk a little bit more about hospitalization. And then as another note, just urge some caution in reviewing the lower case counts or case increases. We are hopeful that this will continue, but we are skeptical because we know that over the Christmas holiday and that weekend, there was less testing being done. So we think this is probably artifact of fewer tests being performed, therefore fewer positives. So we anticipate that these numbers will go up and that our hospitalizations will also reflect that. And we also anticipate that our hospitalizations will reflect a larger burden of disease than the new cases do over time. And also, before I get to the benchmarks, I want to just bring up to date on vaccinations. We are currently vaccinating those who fall within the 1A1 and the 1A2 category. Sorry about that, Kelsey. Okay, thank you. There we go. As identified in the statewide plan, which you can see the new phases that they put out today before you. We'll be holding a clinic this Saturday at the Expo Center for folks who meet those qualifications. I forgot to add in the older than 75 starting New Year's Day is also part of the category. So the idea is that we will concurrently be vaccinating the high-risk employees as well as the high-risk people based on their age. So this new approach recommended by the Advisory Committee on Immunization Practices. We will be at the Expo Center from 9 a.m. to 2 p.m. or until vaccine runs out. The details were sent out in a news release and been posted on our website, and we'll be scheduling and announcing additional clinics as we receive more vaccine. 1A1 includes inpatient healthcare providers, first responders with direct exposure to the public, and staff members and residents of long-term care facilities. 1A2 includes primary care, those primarily working in outpatient healthcare settings, and again, you can see the full breakout here. The addition, a recent addition was including those who perform mortuary services, as they have exposure to folks who've died from COVID. And so as far as total numbers, you can look at the state's website and see the numbers of vaccinations. We only know the number of vaccinations we administer. We don't track the vaccinations because hospitals are vaccinating their staff, pharmacies are vaccinating nursing homes and assisted livings. And so there's a lot of vaccinating going. So the more accurate place to get information about COVID-19 vaccine in Tennessee is really the state's website. And so I would point you in that direction if you want to know more about total numbers of vaccines being given. And so we will be able to tell you how many we gave, but not how many everybody else gave, because we don't track that. So now we'll go back to the benchmarks. Apologize for that, my people who are helping me with the display. So we'll move on to the first benchmark, sustained reduction or stability in new cases for 14 days. Over the past 2 weeks, our case counts remain high with an average of 391 cases per day. We want to note that the data over this time period didn't have any consecutive red flags. However, we have seen a sustained high volume of cases, which is not a place where we want to be as a community. Because of this consistent high volume of daily increases, we are continuing to represent this benchmark as red. And if you think about the benchmarks and the way the flags work, they're based on previous numbers. So if we get up to a really high number and we just stay there, kind of in the neighborhood, we don't have flags. But that still is not acceptable for case rates and new cases. So when we're at this high number of new cases, averaging 391, we really consider that to be a red for our community. Our second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result reporting time turnaround. The total number of tests conducted has decreased since the last reporting time, but is consistent with previous weeks and could be reflecting the holiday weekend. The issue we're continuing to see is lab turnaround time. So remember, this is the last 2 weeks, not more recent time periods. So over this time period, we are continuing to see an average turnaround time of 6.5 days in our community. And again, this week we've seen an improvement, and we expect our next benchmark to reflect that. So we're hopeful that turnaround times are improving, but we do continue at this time to represent this as red. Third benchmark, sustained or increased public health capability. Based on our internal assessment of our capabilities and acknowledging the need to prioritize our case investigations and contact tracing, we are representing this benchmark as red. We continue to use our resources in the best way we can, with the understanding that resources are not unlimited. We are consistently looking at ways to best accomplish this as the situation continues to evolve. So we're still able, because we've made changes, we're still able to reach out to most of the cases, but because we've had to make changes and because we continue to look at that, we are continuing to represent this as red. Excuse me. Our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. During this time period, flags were noted for positive inpatients, ICU patients, and ventilated patients. Numbers remain very high, with yesterday marking the greatest number of COVID inpatients to date at 627, and that's for the region, not for Knox County. After speaking with our hospital partners, we continue to represent this benchmark as red. And our fifth benchmark, sustained or decreased COVID-19 related death rate for identified positive or probable cases. Deaths have continued to increase in our community. During this time period, we have seen 58 deaths associated with COVID. So that's the last 2 weeks. This is an average of 4 deaths per day, which I said previously, which is up from 3 from before. This is not the direction we want to continue down, and the information available leads us to represent this as red as well. As of Tuesday, our 14, and so the supplemental data, we'll look at that now. As of Tuesday, our 14-day trend line showed 83 new cases per 100,000, and our 7-day trend line shows 60 new cases per 100,000. If you remember, our goal is to have those down the 28 or the 14-day down to 10 cases per 100,000. So we're well above that. The second chart shows the percent positive for COVID-19. This data is received from the Tennessee Department of Health. Our 7-day average percent positive is 20.8%. Again, our goal is to have that around 10%. So we're well above that. And so that's what I have. If anybody has any questions, I'm happy to answer them.
Dr. Buchanan,
Yes, sir.
this is Mayor Jake. In regards to vaccine, I know it's a bit of a target, but you guys are doing vaccinations, hospital vaccinations. You said the nursing homes are that's being provided by CDC.
Yes. So some nursing home, well, no, all nursing homes in Knox County, as last I was informed, are participating in the Walgreens and CVS vaccination programs. And I think those roll out this week in Knox County. I know they've rolled out in other parts of the state sooner. And so we're hopeful that those will roll out. Some assisted livings are also participating in that. The assisted livings that are not participating in that program, the state is working to get them to be able to have access to vaccine in a different way. But we will probably be helping vaccinate some of those smaller assisted livings in the near future. The other group that we'll be helping to vaccinate are the folks with disabilities. So the folks who live in developmentally and intellectually disabled home, we'll be helping vaccinate those folks and their staff as well. We'll be starting that, I believe, next week. So it's certain groups that the health department is responsible for vaccinating in these early phases. In later phases, we will be opening it up and having everybody come get vaccinated, and hopefully in the not too distant future, you might even be able to go to your local pharmacy and get a vaccine, even if you aren't in a nursing home. So we're hopeful for that.
Dr. Buchanan,
Yes, sir.
Go ahead. You might get an echo.
Not for me.
Okay, good. I have a question about the timeline for the vaccines. I know at UT we've had somewhat of a small speed up in our timeline, and I was wondering if that timeline that was on the graph about when the various subsets rollout is accurate, or if that's been sped up a little bit.
Well, I think the timeline will vary. So that timeline are just estimates. The timeline you saw are just estimates of when those phases will occur.
Okay.
And so if you take a small county where they don't have a lot of first responders, they finished vaccinating the first responders pretty quickly and moved right on to the 1A2 group already. And so it's going to look different in different institutions. And even among your hospitals, depending on what the uptake was among medical staff, they may have moved on to other categories. So that varies greatly between organizations and communities.
And Dr. Buchanan, the other question I had was about turnaround time. I know in a hospital setting, our turnaround time for PCR COVID testing is 2 days maximum for testing for elective surgery, and it's really less than that. And I know the turnaround time for the machines themselves are really in the order of about 6 hours, although the assembling and reporting take longer. But it seems like that turnaround time of about 6.5 days is pretty long. Is that include the commercial labs, or is that strictly run through the health department, or where does that data originate?
That data originates from the Tennessee Department of Health, and it is from all of the labs in the state that are doing COVID testing.
Okay.
So the commercial labs, the state lab, everybody across the state. And we just really had some hiccups in lab testing and turnaround time, with one of our big testers having a really big challenge with some changes and some problems that they were having. So some of us had to shuffle over to a different testing facility. But in the meantime, our turnaround times skyrocketed. In addition to that, we had a real big backlog in the reporting system. So all of that combined, really, really delayed reporting. So the reporting system has been cleaned up, and it's working more smoothly. Most folks have switched to a different lab that has a better turnaround time. The lab that's having problems, I believe, is working on changing that and getting back online as well. So we are hopeful that the turnaround times all of us will have turnaround times similar to what you're seeing at the hospital. I know the lab we're using, we actually have a 24 to 48 hour turnaround time with them, which is, I think, what you're seeing more often in the hospital as well.
Appreciate that. Any other questions for Dr. Buchanan? Comments regarding our benchmarks, or any other comments on her report?
This is Maria. This may have been said and I missed it, but to Dr. Buchanan, when we receive emails, we on the Board of Health receive emails from people wanting to know, when can I or my loved one get vaccinated? We've had several emails in the past 24 hours, people very concerned about their frail and vulnerable, elders in their families. Should we just refer them to the link to the Tennessee site? That people want to know specifically, like in our county, when the rollout is going to be. And I understand, and we all understand, if you've explained to us, it's going to vary from county to county, facility to facility, etc. But where would you recommend we direct people when they email us with wanting to know what the most up-to-date information is?
Really reasonable question. So 2 places. One, the State Department of Health is one place, but I'm not sure they're going to be able to get the county to county data up there. We are going to be posting, I think we said today, daily, but it won't change all that rapidly, on our website, which groups are eligible, along with the definition of that group. And then, honestly, they need to, check out our social media, pay attention to our news briefings. We'll be announcing vaccination events through that, and putting out through all the different media outlets, social media, traditional media. So we'll be announcing those periodically. And so pay attention to those outlets as well. And we get, there's a lot, I'm happy there's a lot of interest in vaccine, honestly. but and the rollout is always a little awkward and jumpy. So we're hoping that we'll kind of hit our stride, and we'll have some regular vaccination clinics and people that can come to.
Thank you.
Could I ask a related question? And this has come, and I know you probably don't know it, but I want to at least put it out there. Have you heard anything from Walgreens or CVS and I think Kroger, who are planning to do public vaccinations? I know my local CVS has actually already set up a clinic in the parking lot. So I didn't know if any words have come to you all at the health department to know about when they may initiate their plans.
So I don't have the details of that, but what I do know, and I think this was a smart decision on the state's part, the state is working with those big providers to be able to offer vaccine to increase access. So they're not necessarily going through your private provider like they do sometimes with other things, but they're going through those big providers that have much more variability on when you can go see them and get a vaccine. And I think that's a good idea. It provides a broader spectrum of access for the public. So I think those folks will be online soon. They're really working hard to get them up and running quickly so that they can start helping with this very big piece of public health prevention.
Thank you.
Sure.
So Dr. Buchanan, maybe just one kind of nuts and bolts question. When the rollouts are occurring, is the vaccine being shipped to specific places? In other words, in the first phase, that the A1A portion all went to hospitals. That was the Pfizer vaccine, and then Moderna was going to pharmacies as well as the first responders. So are those big providers in line to just independently starting to get their supplies, or are they on hold for the others to play out? Or how does that work, that they actually get the vaccine and start working with it?
So I'm going to apologize, one, because my dog is jingling the jingle bell that hangs on the door to go outside. I'm at home. So you're going to hear that. Apologize for that. When we get done, I'll go let her outside. Sorry. So the State Department of Health and the federal government are managing vaccine delivery. So the hospitals received Pfizer vaccine directly from Pfizer. We received Moderna vaccine from the State Department of Health, which came probably through their logistical manager, McKesson. So it's coming from variable sources, and it's being shipped out as it is available. Everyone's being asked to follow the priority phases. And for the most part, people are doing that to get the elderly and those who are working directly with patients vaccinated first. And I think that's a really, if we can get our elderly population vaccinated, we can really help reduce hospitalizations and have an impact on our deaths in our community. Not that everyone who's hospitalized is elderly, but the majority, as we've seen, tend to be older.
Thank you.
Dr. Buchanan, just to switch gears, I had a question back on the benchmark presentation. Although I think I like this talk about the vaccine. If there's anything good we can be talking about, it's that. Could somebody project the part again about the hospital capacity piece? That'd be possible. Anybody?
Kelsey?
Yes,
You-
give us 1 second. I think Danielle should be able to do it.
Oh, Daniel's doing it. Sorry. Thanks.
No problem. So the table that is below the graphs of the hospital benchmark, yeah, if you can scroll down just a little bit further and a little bit more. So I'm talking about that surge piece at the bottom, and I know it's not like there are people who are just really focused on looking at this every day, but I did discuss with our hospital partners about this, and I just want to be very clear, and we've said this multiple times in our prior meetings, but that stated additional surge capacity for all beds, ICU beds, and if you click on that, click here for more information, that just kind of says where that came from, and that's really space and stuff. Okay, that means there is the potential space to expand that much, and there's potentially equipment to do so. That says absolutely nothing about staff. and to the point that I'm going to propose that we put a little asterisk there to that effect, and the hospital partners were okay with that. And so I just want it to be clear that even though that's out there in the public view, it implies that there's a whole lot the hospitals could do. And we do have surge plans, and we have plans that we're actually partly in right now, but to imply that we could do this is not something that we can do because of the staffing piece. So I just wanted for me to be at peace, I wanted to say that one more time in the meeting since it's out there. And I do think we could probably add an asterisk or an additional comment to that just so it's clear. And that's all.
Dr. Shamia, well, I'll tell you, let me wait until you give because I had a question about surge capacity. Any other comments on Dr. Buchanan's presentation on the benchmarks or the county's presentation? Anything else to go over there? If not, Dr. Buchanan, thank you again for all the hard work, and thank you for that very clear presentation. So next on the agenda is the University of Tennessee Medical Center's Knoxville data update with Dr. Shamia. So Dr. Shamia, if you have your slides ready, take it away.
All right, thank you.
You're welcome.
So this will be the basic presentation here that we usually go through. Next slide, please. So I am going to really highlight a point that Dr. Buchanan made probably over and over, and that is that if you see the county and the district this most recent week, that bar being lower, it would suggest that we had fewer cases, which you would think would be a positive thing. But I'm going to show you that really the testing amount was down. And I think that that can easily be misinterpreted as being a positive sign, but we actually view it as anytime you see testing go down in the middle of this, that means fewer people being diagnosed and fewer people being isolated. That seemed to be a holiday issue, maybe even other issues, but we truly feel that reduction was because of decreased testing, not because of decreased cases. Then over on the right, in the county and the district for the month, you just see what a big month in terms of cases December was compared to any other month before. Next slide, please. So this is really in the THA Knoxville district, this is testing. So those green bars and then the yellow dots are the testing volume. And you see in this most recent last several days how much testing actually dropped. And so it would be, I think, incorrect to infer that the decreasing diagnosed cases was because the pandemic has slowed. It really seems to be driven by decreased testing. And we're going to see that over and over. Next slide, please. So that also happened across the state. So it makes sense that it would be more of a holiday artifact of decreased testing, not that the entire state would have simultaneously dropped in this way. But you see what the week before, how high those cases were. Next slide, please. We broke this down into every decade. Every decade saw the same impact of the most recent week's decreased testing. But otherwise, we continue to see, before we would just show you 51 and over, and it would see that spike, but you see that it is actually fairly represented in the 51 to 60 and then the 61 to 70 age groups. And of course, all of those decades are more at risk to become hospitalized. Next slide, please. So positivity rate, the slight dip there at one point and then rising again. We know that decreased testing will also drive up positivity rate, but that is a very high positivity rate compared to what we would want. Next slide, please. Now focus just on hospitalizations. We think that this most recent bar being low in the weeks is related to more reporting delays. You see what the week before was, particularly in the Knoxville district, that 116 new hospitalizations. On the right-hand side, you see where we are for new hospitalizations in the county and the district for the month of December. Also, something important as it relates to hospital capacity is we've said multiple times that patients with COVID tend to stay longer than the average hospital patient. So the more relative proportion of your patients that you have with COVID-19, that has an impact on capacity, not just because those patients are taking more of the beds, but because they stay longer. And you don't have to have a mathematically dramatic effect or extension of your length of stay to really have an impact on capacity. Next slide, please. So this is the Knoxville, the daily hospital census, the number of patients in the hospital each day. Because of holiday reporting, there were some gaps in the data here. So where the numbers are, the 528, the 444, and the 543, we feel very good about those numbers because they seem to have full reporting. So there did seem to be a drop, and now we're very much in another rise. And I can tell you just at our hospital, from the Tuesday before Christmas to the Monday after, we saw a significant increase in our hospital census of patients with COVID-19. Next slide, please. And then this is the projections. You see that there was that one trend line going downward that correlated with that 444, but then the other three have pretty much been steadily rising. And the most importantly, the one that is from this week is projecting to continue to rise. I've always said that the more of those that line up together, the more we just have a general sense of what's going on. I wouldn't fixate on the specific numbers of the predictions. And I believe that is my final slide. Yes, it is. So I'll be happy, Dr. Gocher, to take any questions.
Okay, any questions for Dr. Shamiya regarding his report? If not, Dr. Shamiya, I had a quick question about surge capacity, because in your comments, which I think are very relevant, that the staff portion of the surge capacity is maybe the weak link in the system. And because other parts of the country have different positivity rates, and in fact, some of those are lower, do we have any capability to bring in locum tenens staff from other parts of the country, or are other parts so widely affected that that's not possible? Has that been explored?
Oh, it's been explored extensively, and that is essentially not possible at this point. And so you have to put it in context that even though there are certainly parts of the country that don't have the kind of numbers that we do right now, they still don't have good numbers. And so, and then the effect of COVID-19 on, the illness in hospital staff and hospital workers has affected every part of the country. We are starting to see that piece get a little bit better. And that's the real big hope of the vaccine, is that as we get more people more weeks out from their vaccinations, that we'll start seeing less and less illness in team members. And so that's hurt us all significantly in the last several weeks. Another thing, though, that I will say is that the one thing we follow is hospitals that go on what's called critical status, which is an indication, I've mentioned it before, but it's an indication to EMS that for whatever period of hours that is, when possible, to divert patients to other facilities, because either their emergency department or their inpatient floors are under significant capacity strain. And that's been happening a fair amount in this week after Christmas. And it just goes to different facilities at different times. But the more of those that you start to see being on critical status simultaneously, which, I mean, we've not had to do that this week, but we've had to do it at times in the past. But there have been times where have been hospitals that have done that simultaneously this week. That's a sign of strain in the system. To address kind of the surge piece of what you asked, the reality is, to do any sort of really impactful surge from a staffing standpoint really starts to mean doing less of something else. And that's just the reality of where we are. And those are, from a timing perspective, can be difficult decisions to make, because it would be so great if we could predict next week and predict the future, but we know that there are some things we can and some things we can't.
Thank you. Other questions for Dr. Shamiya?
This is Maria. I have a question. Dr. Shmee, I'm wondering off the top of your head, or do you have any hard data or a sense of things in regards to your facility and then also the regional facilities? Number of critical status events that have been happening compared to this time last year or usual year, because of course we hear from people who say, yeah, hospitals hit surge capacity every flu season, this is no big deal. And you have said in the past that this is what the healthcare system is experiencing is unusual. But do you have any data? Is anyone tracking that number of critical status incidents per hospital or regionally, or give us some sense of what is happening now compared to the normal flu season strain on the system?
Sure. I can, that may be tracked by someone over at the health department. I don't know if he's compiling that data, but I'm not. But I can tell you that we get a notification anytime a hospital changes their status. So it's a real-time thing. And this is not something that we've experienced, what we've seen in the last 3 weeks as far as that happening. And of course, it slowed down right around Christmas. Is not something that we've seen before. I say that just in terms of knowing when those alerts come across and seeing them. This is not normal for what we would see this time of year at all.
Yeah, and Dr. Hurd, I can ask, I'm not sure if we track those or not, but I mean, we get notified anytime any hospital in Knox County goes on any kind of diversion.
I think that would be interesting data to have and look at together.
So Dr. Shami, about going on diversion, I know when I'm on trauma call that we will jump in and out of diversion for trauma cases. Are the surgical diversions separate from the medical diversions?
Well, there are, and again, every hospital may have their own set of parameters around this. There are certain things that we do not go on, divert on. And so, for example, as a level 1 trauma center, we take traumas. And so there are certain diagnoses that even if you're on critical status, it's understood you're still taking those specific diagnoses, you're still taking those patients. It's more certain diagnoses that, and again, this is EMS traffic. So people in a private car can go to any hospital that they want to go to and they'll be treated. But there are certain diagnoses that can be treated at lots of different hospitals, probably equivalently. And so that is, those are the types of diagnoses. The other thing it's important to understand is that, people still have the ability to say, no, I want to go there, but at least they've been prepped for the idea that hospital's wait, for example, at that particular time may be more significant than usual. But there still is that element of patient choice in that. But it's our ability. It's the one thing that the hospitals can do to try to get some time to decompress whatever situation they have. And then, as I said, hopefully other hospitals are not hitting that at the exact same time.
Thank you. Any other questions or comments for Dr. Shamiya? If not, I want to, thank you again for a great presentation and again, very clear information. Appreciate it. Next on the agenda are questions for the educational institutions, and we have been sent the information from the University of Tennessee and from Knox County Schools, prior to the meeting. Is there any comment or discussion about the data that we have received from either entity?
I think we should just state for the public, because both have been essentially down right now, that there's not much data to review, and we would have to await the new term to see some significant data. So it's very minimal at this time.
So at the University of Tennessee, you might see that second spike, but it's been actually remarkable after the early fall, late summer spike at UT that things have been relatively constant there. So hats off to that institution for containing things as well as they have. Ms. Wagner, any additional information other than the report that you might have for us?
No, we start back to school on January the 4th. The kids come back on the 5th. So we'll be starting school.
Sounds good. Thank you very much.
Mhm.
Any other comments or discussion about our educational institution data?
I have a question for Ms. Wagner. I know that the Knox County Schools benchmarks are public information. It's on the website, how the decision is being made with regard to student absences, staff, custodial, and so on. I'm wondering if informally, does the community situation ever come into the conversation at all? Particularly, I mean, with that last week leading up to holiday break going all virtual, or was it strictly there were just so many pockets that were going red that it was time to call it for the whole district?
We do consider the community, and also we look at, the things within the school, the occurrences of COVID cases within the school, and we discuss with the health department about how we should proceed.
Okay,
So that's
thank
how we.
that answers my question. And it was a question that a lot of other community members had as well. So thank you.
Well, and I'd like to follow up on that question if possible, and maybe for both Ms. Wagner and Dr. Buchanan, is to what extent is there interplay between the hospital situation specifically and the decision about the schools? Because again, that the hospital situation being part of that overall community situation.
I'll let Dr. Buchanan answer that.
Sure, no problem. So we have a weekly meeting with Knox County Schools administrative staff to look at the community situation, which obviously the hospitals are part of the community situation, and look at what's going on in the schools and discuss, questions that they have and make recommendations. And and they take those back to the superintendent, and they make their internal decisions about what they're going to do with schools and extracurricular activities. So that's kind of how it works. We kind of have a session, and then the superintendent makes that decision.
Thank you.
Thanks, everyone. Any other discussion on educational institutions? If not, appreciate the input from both of those groups. Next item on the agenda is review and discussion of 3 sub-items, which are our regulations in place. And so let's start with 2020-1, which is the face covering regulation. Recall that this one does not have a sunset date on it, and it came in on July 1. Any discussions, any updates, any additional information that we need to share on 2020-1?
I just, from our perspective, I don't really have any updates. We still get random, and it's really dropped off, but we still get complaints from people, the public, about places where they are or are not enforcing the mask mandate and different things like that. It's definitely dropped off. I think the thing about the mask mandate, even with vaccines rolling out, it's going to be important to keep that in place, because for several reasons, but one is because even after you get vaccinated, you might have mild illness and you could still transmit it to someone else. So we still need, again, initially we'll have just a small portion of the population vaccinated, which is a reason to keep the mask mandate in place. But even after we have more people vaccinated, and even after you get vaccinated, you still have to follow 5 core actions, because you need to protect those around you. You're protected by vaccine, but you need to protect the people around you. So that's an important message. We'll continue to drive home to our community, encourage them to continue to do that. And I know it's challenging, because people want to go, oh, yay, getting vaccinated. And I don't have to do those things anymore, but you still do to protect our community. So that's going to be important.
Thanks, Dr. Buchanan. Any other discussion on 2020-1 from anyone on the board? If not, we'll go to the next section, which is 2020-7, restaurant occupancy limitation, early closure. Any comments, discussion, feedback on that?
Just a question of as far as the date, that I have to be reminded about the dates on these.
It was extended to 1/6/2021.
1/6.
I'm pretty sure. I went back and looked at the notes. Yes, 1/6.
But our next meeting is scheduled to be the following week, 1/13, is that right?
Yes, that's correct.
So the two are not in sync, correct, on dates? That's where I get.
They currently are not in sync. The gathering expires like on the 1st or tomorrow or something like in the next couple of days. And here they are. And then the occupancy expires in 1/6.
Okay.
Just a quick question. So with the gathering size, how is that related? I know that the governor put something similar in place and it goes until what, the middle of January, I believe. So those two seem to be pretty similar in wording from what I gathered.
They are. Well, they sort of are. He has probably more exceptions than we do in ours. I don't remember the exact verbiage, but the last time I read it, what I recall is that there were more exceptions in the governor's executive order than there are in our social gathering limitation. That from my perspective, ours was maybe a little more clear and restrictive than the governor's is.
So Dr. Buchanan, kind of a legal question, or maybe if Mr. Sanders is on board, he can help us with this. Does the governor's executive order trump the regulations from our Board of Health?
That is definitely a Mr. Sanders question.
No, I don't believe it does, unless it states it has the intent to. But all the governor's executive orders have given the 6 counties with independently run health departments the ability to go beyond what the state has as far as their restrictions. Now, so the short answer is no, I don't believe in these 6 counties, of which Knox is one, that the governor's order limits Knox County unless the governor said something in the executive order that explicitly expressed that intent.
So, Mr. Sanders, the opposite side of that coin, if his restrictions were more restrictive, if his ruling was more restrictive than Knox County, would it trump our ruling?
Yes, I believe so, but I'd want to see, I mean, that's a hypothetical at this point.
Yeah.
So I'd want to see how the text is written. I mean, for lawyers, text is everything. And I couldn't really express hypothetically, but basically when the larger system of government says this is the way it is across the board, then the smaller systems of government have to fall in line. But in the case of the current executive orders, the governor has said, this is the way it is, except for these 6 counties. And these 6 counties have the freedom to enact more restrictive regulations.
Could they enact less restrictive regulations?
Let me get back to you on that one. I'd want to reread his orders, and I do not have them in front of me. As you can see, I'm at home here. So I do not have those orders in front of me.
Appreciate your input.
Sure.
Dr. Coach, I have a question, and since we're technically on 2020-7, it's been brought to my attention, that we are causing any facility to close at 10 o'clock. And it's been told to me that there are several restaurants that have been trying to be actually helpful late at night for government workers, EMS, to try to have a place for them to get in out of the cold and to have a meal. And unfortunately, what we have done with this technically makes them lawbreakers, trying to be helpful to some members of our community. So I just wanted to bring that up. That has come to light, and I'm not sure how to try to fix that unless we would change this from an actual public health regulation to a public health recommendation at this point, and take some of the teeth out of it so that we wouldn't have, some folks who are really trying to be helpful to members of our community who are out there working late at night. They feel they're breaking the law and they don't want to, but they also want to be there to help. Just want to bring that up.
Point well taken, Dr. O'Brien. Any discussion on that point or any other points regarding 2020-7?
So just to be clear, if we do nothing, it would just be allowed to expire before the next meeting?
Yes.
Yes. So if it were changed to a recommendation, what are the thoughts of the board of what would be the outcome of that? And I would like to have input from Mayor Jacobs if he's prepared to go over that with us. What do you think would happen? Do you think it would change anything as far as how our restaurants operate? Would it allow these kind of needed exceptions that Dr. O'Brien talks about? Would it create a problem, or would it solve a problem, or would it be neutral?
Well, I think one thing to keep in mind is the Tennessee pledge is still in effect, so the restaurants still have to abide by that no matter what the board does. In addition, as Dr. O'Brien pointed out, we're looking at restaurants that stay open late, more so. I think it's important for those restaurants in particular. Of course, I'm going to say that it would be very helpful if we would make this a recommendation. From the public health perspective, just from what I've read, it doesn't appear that there is huge amounts of virus transfer at restaurants. In that respect, that's your all's domain, not mine. From an economic perspective and a public service perspective, it would definitely help if this were made a recommendation that everybody could keep in mind.
Thoughts from the board?
Since we're talking about this, should we, talk a little more about this? Is this the point at which we might want to change this from a regulation so it doesn't run out all the way? That's one option, and make it a recommendation. Or we have to fall back on the Tennessee, what we're doing statewide.
Well,
so, that's still in force.
Dr. O'Brien, this would be at the pleasure of the board, and we would need a motion and a second to formally discuss this and take it whichever direction that we would agree on.
Well, I just want to remind everybody, when we put this in place, it was based on some data, not from here locally, but from across the country, where the CDC looked at cases of COVID. I think the CDC did this. I honestly don't remember who did the study, and found that the majority of cases of positive people versus negative people had eaten out in the 2 weeks prior to. And so limiting or closing restaurants early has consistently been a recommendation of the White House Task Force. It is not in the current White House Task Force report, which is interesting, but it has consistently in the past been part of their recommendations. And so certainly if Dr. O'Brien is able to carve out an intelligible exception for the restaurants he's speaking of, that might be an option. But that's hard to carve out. So I think with UT coming back and school getting back in session and coming off the holidays, just not, is this the time to let this expire?
And
Just correct me if I'm sorry.
No, go ahead.
Dr. Schmid, go ahead.
Well, I was just going to bring at least the part about the meal piece is, I don't know to what extent takeout, and I understand that for some places just operating takeout at certain hours may not make sense, but I don't know if Dr. O'Brien, to serve the purpose, or at least a decent portion of the purpose which you state, is them of being able to provide takeout at that later time. And if that's really opens the door to something broader, because I would be uncomfortable knowing the data that Dr. Buchanan described, unless we can carve something out, it's kind of balancing these issues. But to do something across the board to just address the point that you made, I think I'm uncomfortable with that. But if there's some way to serve that need without doing something broader, I would be receptive to that.
What the group I'm talking about are like KUB workers, EMS, late at night, getting out of the cold. So, if I put an exception there, I would do it for restaurants that would be open for indoor on-premise serving of emergency and other, public service workers. And there's only a few restaurants that are doing that. It would be limited to those people is what I was trying to think of, so that they're not basically breaking the law. They can already do takeout. Takeaway is available based on how the regulation's set up. But to have a place just to get inside without getting rid of the rest of the regulation is what I would like to see if we could propose. Like I say, public service workers only. So it would not be open to the public. It would be open to a limited group is what I was trying to accomplish.
Dr. O'Brien, I might have a difficulty with that based on just having a limited group of people eligible. I think in a way, the hour that you're speaking about is a limited group of people. There aren't a lot of people out at 3 a.m. wanting to have breakfast, but there are some. And I would probably tend to keep it more, my personal choice would be to keep that portion more open, but trying to craft this is I think quite difficult.
And the other way to do this is just realize that we could tell those businesses that are being helpful, nobody's going to come after you. We're not going to recommend somebody comes after you. I don't think they are anyway at 2, 3 in the morning when they allow in a group of, like say, line workers or some other people that are out there, or EMS or police officers off the street. So, we could keep it as is, but just kind of publicly state that, we'd have no intent for a limited availability to be basically breaking our public health regulation. I think keeping the regulation is very worthwhile. We do have some businesses that we're having difficulty with in the community that I think are not following the spirit whatsoever of the regulation. And it is a public health regulation, not a recommendation. And I think we need to be firm on that aspect of it. But I just wanted to at least, like I say, bring it up. I don't mind leaving it as is, but we just need to maybe put the word out there that, for kind of individual cases, we're not going to be worried about those.
Where does alcohol? I'm sorry, go ahead, Dr.
No, please go ahead, Mayor.
Where does alcohol sales play into this? Initially, when we had these, we talked about bars and alcohol sales. And we, I think, migrated more into all restaurants, but would it help if instead of being a restaurant curfew, it went back to being an alcohol sales curfew? That would eliminate some of those restaurants that Dr. O'Brien is talking about. I guess all of them probably.
So, so alcohol sales certainly play into this. That one report that came out about eating out at a restaurant did not discuss alcohol sales. Actually, the White House report recommended actually closing all bars until your positivity rate is down to 3%, which would be a long time. So this was a compromise to do this, and to try not to target just bars, but to, and we, if you remember, we compromised on this based on Mr. Burleson's input. So, I think this is a reasonable compromise that we came up with. If you, I don't know what an amendment would be. I mean, obviously it expires, so we either need to extend it. I don't know if we and Mr. Sanders, you might need to help with this. If we chose to say extend it to 11:59 a.m. 1/21/2020, then could we amend it? I'm just not, do we amend it before or amend it after? Just not sure how that would work.
You can amend it now, or you can amend it in the future. I'm actually trying to draft some language right now for a proposed paragraph 3D. Paragraph 3 of your regulation is the exceptions. And I'm almost finished typing it, and I was going to shoot it off to Dr. O'Brien and to you for one of you to propose to the board that gets the fear, I think gets at the spirit of what you're saying. If you go into the exception section of that regulation 2020-7, and you go down to the exceptions paragraph, which is paragraph 3D, and the next one would be 3D, and simply add any service to public or private primary care or first responder employees who are required due to the needs of their employment to use such facilities. And you could add whatever conditions you want to that. So whether you want to, for instance, add that, alcohol would or would not be required. I'm not trying to get into the making policy. That's your job, not mine. But I believe you can fix this problem you're discussing by simply adding an exception paragraph in that regulation.
One way to do this, it might be simpler, would just to have restaurants work at their regular hours for food service only, with the proper spacing and proper social distancing, but having a time limit on alcohol, which I think we've looked at that before. We've at least thought about that before, but that would solve this problem, and it would not be necessarily discriminatory against maybe a long haul truck driver that's coming in that might want to have something at 3 a.m. He's not a first responder, but he could benefit from those services. So if you try to get too specific, it could be tricky.
But that long haul trucker can get takeout still.
Yeah, thank you. This is Maria.
Yeah.
But
This is Maria. I have a couple of concerns that are very pragmatic, I think. One, the situation of infection, hospitalization, and death is not getting better, specifically in our community. So to me, it begs the question, why are we discussing lessening restrictions to make minute exceptions? People could get takeout. Surely first responders understand that. Please don't misunderstand me, anyone who's listening. I am in full support of our first responders of every stripe and caliber. But they understand cold nights, you stay in your vehicle and you can get takeout. So that is an option. We're not limiting them, and we're not asking anyone to break the law by serving them. So we have things in place to accommodate these special heroes, people on the front line. If we start making exceptions, well, people can, they can stay open, we can have them come seat them. I mean, do people really need to be sitting in restaurants and being served? That's a good question to ask ourselves. And two, what's to stop every business in town saying, well, we serve first responders, at 2 a.m. So to me, these are very practical questions for us to consider in the larger context of, is now really the time to talk about lessening the mitigation measures that we put in place?
I really didn't mean it to be that concerning for everybody. I was hoping to just let people know of some of the folks that are out there, some of our KUB folks, the linemen that are out late at night. And we have had an owner who has been kind of taking care of them, letting them in out of the cold. So we can move forward as is with just an understanding that we will not encourage anybody to go after an individual restaurant that's helping out our people. I mean, we're looking for egregious problems out there, and that's really where the issue is. So I think we do need to have this regulation in almost all of its entirety continued. And, but I just wanted to at least see if there was one way to make that small change, but we don't have to. And then I think we could just let them know that they should be okay.
Any other discussions on 2020-7?
Make a motion that we extend it to 11:59 a.m., 1/21/2020.
Second.
So we have a motion and a second for extension of 2020-7 to 1/21. That'll be about 3 weeks, something like that. Any discussion? Comments, concerns? Since there are none, are we ready to vote? If so, Kelsey, if you will go through a roll call for a vote on 2020-7, please.
Absolutely. This is Kelsey Wilson with Knox County Health Department taking a vote. Dr. Gocher,
Yes.
Dr. Hurt,
Yes.
Mayor Jacobs,
No.
Dr. O'Brien,
Yes.
Miss Roma,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Miss Wagner,
Yes.
and Dr. Buchanan.
Yes.
All right, that is 8 yeses and 1 no.
Thank you. We have extended 2020-7, so the next item for discussion is the social gathering limitation, which is 2020-8. And so the floor is open for any discussion on that item.
To get the discussion started, I make a motion that we extend it to the same date, 11:59 a.m., 1/21/2020. So they get.
Second.
Second. Dr. Sousa, motion and a second, further discussion. Any comments about that at all? If not, since we are ready to
Just bring up I just want to bring up one thing there. I have had some concerns brought up again on this one about, and I think it's pretty clear, but some people don't think we're really clear. And I've also had them also ask, could we make it a recommendation versus a regulation? So I just want to state that there has been some feedback in that regard.
This regulation is one that interlaces with the governor's. So we still have that question about, are we more strict or less strict right now? Probably need to look into that a little bit more. But if we did nothing, the governor's regulation is still in place. But if ours varies from his a little bit, my opinion, it would probably be reasonable to extend it while we research that sort of quandary about whether we are more restrictive, less restrictive, whatever, because we don't know the answer to that right now. Comments, questions, any other discussion?
Dr. Gocher, I just don't want us to lose sight that the governor did do that. I mean, the state since Christmas, if statewide, there's been a 16% increase in hospitalization for the TDH. And so, I mean, we can talk about more restrictive, less restrictive, but the fact of the matter is that's something that was, endorsed at that level because of the level of concern. I think hospitalizations is what drove that. And so I'm certainly in favor of the one that we have, but I don't want us just to lose sight in talking about the details that came across from the state level, which I think was a sign of concern from, in terms of their stance, where the state is.
Dr. Schmidt, I think my comment would be that it certainly makes sense to continue this from our standpoint because it's essentially already in place. Ours might be either more or less restrictive, but we don't know those fine-tuned answers. So essentially we are either sort of vouching for what the governor's already said, or maybe just fine-tuning it for our county. Either way, it's the same thing.
And just, I guess, one last comment on both of these ordinances is that, the idea is we can only regulate so much, right? And we've got New Year's coming up tomorrow night, and we're hoping that people take the spirit of both of these into their homes as well. Obviously, we can't regulate what you're doing in your house, but If you are going to get together for the New Year's, make sure that it's with your household, that you're not having a big blowout party, because that's really, how we get into these sticky situations. So just take it to heart and bring it home with you too.
Thank you, Dr. Sousa.
And I want to echo, as somebody who worked at UT many years on Christmas Eve, Christmas Day, New Year's Eve, lots of trauma occurs. People need to stay home. I'm just going to say it. I had many bad nights working there because people did not listen. They had too much. They got on the roads. So we have that as one big thing, a big piece of public health in our community that needs to just be stated. It's safer to be at home. Do not gather, and let's get through the pandemic. But we also don't need any trauma. I don't want any of my colleagues out there having to take care of family members, the next couple days. And so let's just really strongly encourage people to watch it and to be careful. We want them around next weekend and next year.
It's interesting, Dr. O'Brien, the times I've been on call either on New Year's Eve or the 1st of January, for our service, it's been more busy on the 1st of January because all the inebriated people finally filter down through regional emergency rooms and start hitting, on the 1st. And it really is quite busy, sometimes on the 1st, actually.
Very true. And people realize they're hurt worse after something happened to them and they show up.
Keeps you busy.
Just a final quick comment. I know that I personally am looking forward to going to bed very early tomorrow night and getting 2020 done.
The French have a saying, they don't say Happy New Year, they say Happy End of the Year. And I think that's a great sentiment, especially for this year.
I will vote no on this, as I always do, but I'm going to echo what everybody just said. This is not the year for people to be partying and going out and doing all that sort of stuff. Along with Dr. Sousa, I will be doing the same thing. I will not watch any balls drop in the United States. I'll probably watch them drop somewhere else in the world so I can go to bed about 9 o'clock.
Any other discussion on that? We have a motion and a second. I sense it's time for a roll call. If there is no other discussion. So Kelsey, if you'll lead us in a roll call on 2020-8, please.
Absolutely. This is Kelsey Wilson, Knox County Health Department, taking a vote. Dr. Gocher.
Yes.
Dr. Hurt.
Yes.
Mayor Jacobs.
No, but people need to stay home.
Dr. O'Brien.
Yes.
Ms. Roma.
Yes. Yes.
Dr. Shamia.
Yes.
Dr. Sousa.
Yes.
Ms. Wagner.
Yes.
And Dr. Buchanan.
Yes.
All right, that's 8 yeses, 1 no, it passes.
Thank you, Ms. Wilson. So we have completed item 9, item 10. I'm going to turn this over to Dr. O'Brien. This is an agenda planning meeting possibility. So Dr. O'Brien, if you could give us your update or thoughts on that, please.
This comes from discussion with several county commissioners. A recommendation was made to me that we might want to utilize one thing that's allowed under the Sunshine Law to plan our meetings with a brief agenda planning meeting set up on Zoom, while it's Zoom, and it could be in person, on the Monday morning before we have to set our agenda for a few minutes. And this would allow anybody that's on the board to talk among ourselves. Hey, I'm thinking of this. What do you think of this? I'd like to maybe put this on the agenda. Do you see any reason for that? That would preclude things like what I did, where I put something up and then pull it down after getting more feedback. I would rather instead take 10 minutes and get up anybody that's available. I know it's tough on a Monday morning. I've got work to do and everybody else does. But if you're available, get on and just say, let's talk about some things that we may want to talk about on Wednesday. So County Commission, one of the commissioners recommended to me that idea, and I thought that was a good one. And it would be just something where we would set aside in sunshine a agenda planning meeting on Mondays at 10 a.m. on Zoom. You could attend or not, maybe nobody'd show up, but it would allow us to show up and talk for maybe 10 minutes about anything we want to put up. And right now, the way things are going, we may not have anything else to put up. So I just wanted to bring that up, see if anybody wanted to follow through with it.
So what I would ask, if we do decide to do this, that we wait until I have some dedicated staff to support the Board of Health. I know it's a quick 10-minute meeting, but a quick 10-minute meeting involves 2 or 3 folks from IT, 2 or 3 people from my staff, and sure, they'll do whatever I ask them to do. And the IT, Zach Webb, has been great to support us. But I just, just to realize kind of that level of support that's needed, it would be helpful if we could wait until we had, and those positions have been posted. We'll be interviewing hopefully this week or next for those 2 positions. And obviously they won't be totally up and running yet, but it'd be nice. We've also lost some other support staff. For my administrative assistant, we'll be replacing her as well. But just a thought.
So Dr. Buchanan, is an alternate way to do this. I would assume that we are able to communicate with the public's knowledge via our emails on the county website. Is that true or not true?
No, sir.
It's not true.
I think it's a good idea. Agenda planning is a good idea. I totally support it. I just, if we could delay the start of it for a little bit would be helpful.
Let's wait until you're ready. I just wanted to bring it up as something that gives us another tool, since we never got that planning platform that was available to us and then was not available. So we'll wait. I'm willing to wait until you're ready.
This is Maria. I'd like to say, I also don't think it's a bad idea, but my teaching schedule on Mondays is back-to-back teaching classes, and there's no give in my schedule. And so for someone who would like to participate, anticipates wanting to participate in an agenda planning, even for 10 minutes, I'm never going to be allowed, I'm never going to have the freedom to leave my job and come do that. So, I don't know what kind of workaround. It gets more complicated the more times we agree to meet. Even for a few minutes. I just want to point out, not all of us have that kind of flexibility built into our work schedule.
And this would not be something anticipated where everybody needs to be there. It's just somebody who wants to bring up something and at least one other member to bounce the idea off of, potentially. So we can leave it as is, as a thought, until we're told it might be possible.
I mean, one other suggestion that I would have is, it means going back to weekly meetings, but County Commission's Agenda Committee meets, is it 1 week or 2 weeks before the work session? So 1 week before the work session is when they meet. So if we were to do it the Wednesday prior to the meeting at 5 p.m., that also gives whoever decides to bring an agenda item time to develop it with Mr. Sanders if that's needed. So that's just another suggestion.
Any other discussion on it? I sense we may not be ready for a motion on that, but it's just, something to think about, see what we can concoct. I agree with the idea. The execution might be difficult. Dr. O'Brien, it might be difficult for me. Some Mondays I'm in the operating room, other times I'm completely involved in other stuff. So it's not a predictable time for me. I mean, I could try to make time, but it might not be always an easy thing to do. And I'll bet you that
it's not a good time for anybody.
Yeah, I bet it goes across the board for everybody, Any other discussion on that? If not, thank you for initiating that, Dr. O'Brien. It's a very good thought. So next item is possible need for an assistant public health officer to be added to the staff. So Dr. O'Brien, Give us your thoughts on that, please.
This came with some discussions in the last week. And my thought on this personally, after talking to some others, is we as the Board of Health need to look down the road. This has nothing to do with today. This is not necessarily because of the pandemic, but something long-term to see if there is a need to have an additional public health officer and assistant that could be budgeted in the next year if desired and felt to be needed by Dr. Buchanan. And this is purely if she would want it, but to have another public health officer under her wing so that over time it may be somebody that she would work with to, you know, at some point, I hope she gets to retire from this job. And I want her to retire on her own terms. And I want her to have the right person in the job. And one of the best ways is to have a good assistant. So I just want to bring this up for discussion, or just to bring it up. We don't need to talk about it much at all right today. It is not something that needs doing today, but I think it needs to be thought of and talked about. And if it is a good idea, we feel as a board, that we would then do the planning with county commission and those who do budgeting to budget and plan for that maybe in the next year. So that's all that was.
Thoughts? Dr. Buchanan, what are your thoughts on that?
Well, what I would say is that we have really reorganized in the last year or two at the health department, created some new positions that really support the work that we need to do and the work that we want to do. And so having an assistant public health officer really hasn't been part of that reorganization or part of our planning. We haven't budgeted in the past for a assistant public health officer. Certainly if I felt that I needed one, I would budget for that and ask for that position. I understand what you're saying. Succession planning is important. And I think as I look down the road and think about that, that's something that I would want to consider at that time. Currently, you know, we are just with the reorganization and creating some new positions, that has freed up some time and really is honestly working well for us. And so I appreciate the consideration. And the other thing is that as we look forward for the future of public health, you know, I think in the big picture of public health, I think more about succession planning when I'm ready to do that would be the time to think about, you know, looking at a successor, because I agree. There hasn't, in the past, there hasn't been a lot of succession planning happen at the county level. Oh.
Are we still on? Can everybody hear okay?
Yeah, I think we lost Dr. Buchanan.
Yeah, I think
That was her going offline.
Yeah. And Mr. Sanders,
Can someone text her and let her know? She may, I'm assuming she's figured out that she's frozen and lost.
Mr. Sanders, just for the board's knowledge, the public health officer that is appointed actually by the state with consultation with the county mayor. Is that correct? Or is it the senior health?
The health director is, I'll have to pull up the statute real quick because
Back.
Hey, Dr. B, sorry.
I'll answer your question, Mayor Jacobs, after Dr. Buchanan finishes. I'll have time to look at that.
So again, just thinking about succession planning, you know, certainly having somebody to succeed the health officer hasn't really been done traditionally. And in the past, the director of the health department has been appointed strictly by the mayor. No involvement of the commissioner of health. The health officer is hired by the director of the health department. That's been the precedent in the past. I've been here 16 years. None of my predecessors that I'm aware of there was no involvement of the commissioner of health. I know what the TCA says, but that has not been in practice what's happened. So yeah, my computer died, so now I'm on my phone. Sorry about that.
good to have you back. Any other discussion on that item? If not, will go on to other business. And does anybody have any other business to
I
go?
guess, Sanders, did you want to say anything about the Commissioner of Health and stuff?
What I can tell you is that the county health director, which is one of the hats you wear, is, according to statute, as you say, appointed by the Commissioner of Health. And the county health officer is also appointed by the state commissioner of health. I believe it's the health director who is appointed with the concurrence of the county mayor, but I'm not seeing that line in the statute offhand. In any event, if Knox County's practice is different, then that's an entirely different situation. We probably need to address it in a forum other than this one.
Any other business to go over? If not, I have a question for Dr. Buchanan. And that is, when the Board of Health in our previous pre-COVID life met about 4 times a year, we had a lot of other things that we discussed, and we always had a budget meeting that came up in about February or March sometimes. And I know that we are required by TCA to produce that budget, among other things. Is there anything else that we need to be working on other than COVID that's, kind of come up behind us because we've been concentrating on COVID? Anything else going on?
So we, just to bring an update on a health department, what else we're doing. We will be releasing our community health assessment this week. You all will get that, you'll receive that. And I can do the Reader's Digest version next week or next time we meet, because it would be too long to do for the whole thing. And then we also have released our strategic plan for addressing substance misuse in our community. The All for Knox plan has been released, and actually we're convening some implementation teams to start implementing some of those things. And Amy is actively working with folks to do that. So those things are going on. We are still, unfortunately, we're still in our coop because of the rising cases. We talked about hoping to get people back to their regular work and doing more of the work that they've been doing, and the very important work they've been doing in the past. But because of the rising COVID cases, we've been unable to do that. We continue to look at how do we prioritize what we need to do, but the trial is being released this week, so the community health assessment, and then we have that strategic plan for addressing substance misuse in our community, which is certainly a big issue for our community. So both of those things are being released. One's been released, one will be released. So, we are not currently actively doing much other than COVID response right now. We're still continuing to treat TB patients and diagnose and treat STIs, and providing some childhood vaccination, providing childhood vaccinations as well. So doing some of those services. We continue to provide WIC services. Actually, we're doing those virtually, and their participation is higher than it's ever been, which is pretty combination of the economy and the ease of access, I think, is what's driving that. And we're doing some restaurant inspections still because we're required to continue to do that. But, I think when we look at the community health assessments, certainly there's some areas that are more concerning than others. Substance misuse, obesity continue to be challenges for our community. Right now, COVID is, I guess, put it in perspective, COVID is killing 4 Knoxvillians a day right now on average. And so to continue to focus on that is really what, for the time being, we need to do. I look forward to being able to shift to something else.
When do we have our budget meeting? Is it in March or April?
It's usually April or May.
Okay.
And so that we'll have that. One of our meetings will be a budget meeting.
Great. Appreciate it very much. Any other business to come before our Board of Health this evening?
I think happy anniversary to
Thank
Dr.
you.
Fisher, I
Yes.
believe.
Thank you. I was going to tell everybody that my wife and I were married when we were 3, but we've been married for 48 years today. So,
Congratulations.
well, thank you. Thank you.
Dr. Goetzer, I have one thing, please.
Sure.
Spoken with a number of county commissioners who have talked with Dr. O'Brien, and I think some of the rest of you all, and I really appreciate you all reaching out to them. So thank you for that.
Thanks, everybody. So if there's no,
And I want to encourage that too. Please, if you have a chance to talk to the county commissioners, they want to hear from us. I've got several wanting to talk next week. I want to just throw that out to everybody else. They love talking to you.
And Dr. Goetzer, I had 2 things. One is very quick, and I just wanted to reiterate, like I do every meeting, that even though I am becoming increasingly concerned just about the hospital situation, we want sick people coming to the hospital. Okay, so and call 911 if you need to call 911. Whatever you would have normally done, do not be reluctant to do that, to engage the healthcare system to seek care, whether it's a COVID related issue or a non-COVID related issue. That is so important right now. The other thing is, and this is just because, I mean, I hate to just completely not address what we know is going on around us with the county commission. And certainly I think those conversations are helpful, but really just a question for Mr. Sanders, just so it's kind of more procedural. So I understand kind of what's happening, but I guess, first of all, do we have any clarity if the county commission does choose to go with their second vote, whether we are simply repurposed or are we dissolved? Is there clarity on that point?
My understanding would be technically the board is dissolved. That is, the ordinance that establish it is revoked, or it's amended, and the board no longer exists. Now it's sort of immediately reconvened, and it can reconvene with the same people. The way this proposed regulation or this proposed ordinance is written, it has the same mechanism of assigning people to it as the current one does. So presumably all of you all could continue to in your positions, although that's not clearly stated one way or the other in the ordinance. But the entity that exists at this moment would no longer exist. There would be a separate entity in its place, and that entity would be called the Advisory Board of Health.
Okay, so then a follow-up question is, if that happens, what happens to the things that are in place at that time?
My presumption is that they cease with the entity. That is, I don't see how, and this is an issue that's been brought up to me in court also, and I'm still looking into it for an absolute certain answer, but my gut reaction at this point is I don't see how an existing regulation of the board could exist beyond the duration of the board. So once the board, because there'd be no one, if they could exist in perpetuity, there'd be no way to unwind them in the future.
And then another follow-up question, Dr. Buchanan, though, who has, I think, at least what's been enacted now, has supported all of those based on her vote, would then have the ability to reenact those?
Yes, Dr. Buchanan, especially under the current executive orders from the governor giving the health departments in these 6 counties the very broad powers, Dr. Buchanan, as the health director and health officer of this county, would have essentially all the powers that the Board of Health has in her acting on her own. Now I think that changes when the executive orders are wound down, when and if. But for the time being, so long as the executive orders say what they do as far as as far as the authority of the directors of health in these 6 counties, then I think she has the authority to continue with these to enact essentially the same regulations.
I'd like to tag on to that. So it's my understanding, so please, Mr. Sanders and Dr. Buchanan, redirect me if I'm misunderstanding. My understanding was that Dr. Buchanan had these powers, and then county law department decided that that was not appropriate and said, okay, we're going to shift that responsibility to the Board of Health. And now that same law department is shifting it back to Dr. Buchanan. I'd just like to, I need some clarification there in terms of
Sure.
on whose shoulders and why this is ping-ponging. I mentioned this
Dr. Hurd,
morning to my husband.
I get the confusion. Here's the situation: is there was in existence a Board of Health at that time that that shift occurred that you're referring to back last June or so. So long as the county has a Board of Health, these authorities rest in the Board of Health, either under the executive order or under statute. But if the county no longer has a Board of Health, then under the executive order, that power goes to the health department, and Dr. Buchanan is the head of the health department.
I'm still trying to process that, because my understanding was that she had that authority and power. I mean, she did. Am I mistaken about that? And then it was deemed that the Board of Health should have this power. We didn't ask for it, people. Help me understand that shift, that transition.
Now, understand, I wasn't here when that happened. I wasn't working with you. I was a spectator watching on the evening news like everybody else. And I haven't read the memoranda or anything. But this county has had a Board of Health since the 1980s. The Board of Health has the authority to make regulations and to govern the health department. If any county that chooses to have a Board of Health, the authority to govern the health department ultimately rests with the Board of Health. Now, not all counties have a Board of Health. It's purely optional whether or not to have one. Right. If the county does not have one, either because it never had one or they choose to do away with it, then what you have left is a health department. In 6 counties out of the 90-something that Tennessee has, there are 6 counties that the governor has deemed as having self-governing health departments or self-directed health departments. Yes. And those counties, those health departments are given a much broader powers than the 92 other health departments are. And in those 6 counties, the head of the health department, who is Dr. Buchanan, whatever entity for that matter is the head of the health department, has those powers. Right now, those powers rest with the Board of Health. Now, the Board of Health also has statutory powers, which frankly probably trump whatever executive order powers. Dr. Buchanan herself, either as her role as health director or health officer, does not have the same level of does not have those same level of powers absent an executive order. But so long as the executive order is in place, her powers are increased. The the Board of Health's powers probably are not, because the Board of Health has a very large power under statute. But the fact that you have a Board of Health is purely optional with the county.
Yeah, I understand that. Thank you. Just to be clear, and again, I agree with my colleagues who said at the last meeting, I believe it was Drs. Shamia and O'Brien who said, as long as somebody is at the helm making decisions, I don't have a personal investment in, needing to be the person that's part of the team that does this. But my understanding is, okay, so we're dissolved, we become an advisory body. That's I think that's correct, which is fine. Doesn't that put our public health officer slash health director, Dr. Buchanan, in the same position she was in previous to the board being assigned this responsibility, which is she then has an advisory task force? My understanding is that that was the dynamic pre-June Board of Health.
Well, that's what was being done, but that's not what should have been being done, because you had a Board of Health. The Board of Health simply wasn't doing what it was supposed to do. And I'm not trying to fault you because you didn't know you were supposed to be doing it. But the authority in March and April and May and June rested with the Board of Health, not with the health officer, because there existed a Board of Health. That's the situation. But, and frankly, it took us all a while to get up to speed on that. This is all new for all of us. But the Board of Health should have been exercising what authority it had the entire time, because it existed the entire time.
I understand. Mr. Morton Myers made that very clear on our first meeting.
Okay. And I wasn't.
Yeah, thank you.
Mr. Morton.
I know that was pre you. Thank you.
So Mr. Sanders, this is not a question now directed at you. This is more of a general statement. But what I'm taking from this is functionally during the middle of the pandemic, and guys, I fully expect that at least the hospital situation will likely be just based on patterns, likely be worse at the time of the county commission meeting than it is right now. But just based on the functionally during the pandemic, whether it's a Board of Health or whether it's Dr. Buchanan, the decision making the outcome will likely be very similar. And that's Dr. Buchanan has said that, and they've said that they support her in that. And so I guess I'm struggling with the timing of the conversation, because it seems like this has more of an impact in a non-state of an emergency functionally, kind of realistically, than it does in the middle of a state of emergency, unless I'm missing something.
Dr. Shemaya, respectfully, I don't hear a question there to me, so I
prefaced it was that this is not a question directed at you.
Okay, so yes, you're getting into issues of policy, and those are not my field.
That was directed to everyone else. But to the rest of the group, because I'm just trying to understand this too, because we have to also be prepped to, if we're going to pivot, what does that look like? Because I know in the middle of the pandemic, I don't want to be caught flat-footed not knowing my role. That's kind of part of why I'm having this conversation. So if I mischaracterize what is happening around us, if someone else here, understand Mr. Sanders cannot comment on that, but if someone else here understands that differently than me, I'm all ears to understand what I missed.
Dr. Shemaya, this is my interpretation of it. And anybody correct me if I'm not right on this, but it depends on what the county commission, if this is passed, it depends on exactly what the county commission comes up with. If they decide to dissolve the board, there is no board at all, and there is a kind of a secondary advisory committee that functions under the county commission. That may function as the new advisory board. If we are not dissolved completely but function as an advisory board, we would be doing just what we're doing now, except functioning to advise Dr. Buchanan. So there's two possibilities depending on what the county commission decides to do. My interpretation.
Mr. Sanders, could I ask you a question, please, sir?
Of course.
If we were dissolved, is that not a function to establish another advisory board under the public health officer versus the county commission under the TCA? Or can the county commission make its own advisory board of health separately?
The county commission can certainly create a advisory board. It can create 15 advisory boards if it wants to. It can have as many advisory boards as it feels it needs. And the question, I guess I'm not really clear of your question. There's no mechanism under the Tennessee Code for creating an advisory board to the health department. The health director can do, under the Tennessee code, basically the health director operates as an agent of the state commissioner of health, actually. She takes her direction from the state, not from the county, not from an elected body in the county, not from an appointed body in the county, except for the Board of Health, when the Board of Health exists. I think you're muted, Dr. O'Brien.
Well, yeah, I was. And that's basically, so it's kind of all or none. So if the county commission wants to make some advisory board of health, they have the right to do that versus the public health officer under the state statute saying, I'm going to have an advisory board that I set up, that I pick for me. So
what the state health officer can do, and I'd have to understand, I didn't read statutes coming in here to see exactly what her ability is, but just like any other person in an executive position, she can ask for advice and seek advice from whomever she wishes. Now, in many circumstances, that we ran into this, I believe, early on also, those meetings would have to be publicly noticed. So even this body, if this body were to continue in its existence and in an advisory capacity, and you all wanted to continue to advise Dr. Buchanan, those meetings would still have to be publicly noticed, and they'd have to be held just like they are in public, open to sunshine law.
That's what I was really getting to.
I have a question. So to be clear, you're saying sunshine law covers advisory bodies that have absolutely nothing to do with creating regulations, but just advisory bodies are also
if they advise a person or a body that creates regulation. And again, I'm sitting at home, I'll have the statute in front of me. But yes, if they are functioning essentially to develop policy that affects the public, then yes, those meetings would need to be sunshined, just like yours are now.
Pardon my ignorance. This is my understanding of sunshine law. So that's local, state. Is this so? State level advisory bodies are held to sunshine laws. Federal law advisory bodies. I mean, that's a lot of people held under. I'm just trying to understand the law, and basically, again, as Dr. Shamia said, what our scope of practice is, so to speak, in because we're conscientious people, we want to do the right thing, regardless of our roles.
And if you want something more, we can take it offline some other time. The forget about federal law, doesn't apply to what we're talking about. Forget about the feds. The state created the sunshine laws to apply to all other government entities except themselves. So they exempted themselves from a lot of the requirements that they hold local governments to. But it does apply to local, county, municipal governments. And it applies to some states' government functions, but not others, as I understand it. But since I'm not a state attorney, I don't worry about that.
I've served on a state committee, and we had a sunshine. I'll just tell you, for years that we had to do a sunshine notice for all our meetings.
And I believe that. The State General Assembly has exempted itself from certain aspects of the sunshine law, I know, but I don't know how far that extends. I've never had needed to know.
So like even mayors or city Mayor Jacobs, they have people advising them. They're also.
If the mayor, and again, we're getting very hypothetical. We're getting way away from this. Essentially, there is a break point. If you have a group whose purpose it is to give advice on a regular basis in a meeting, then yes, that meeting needs to be sunshined. But obviously, all executives have people who advise them, and those meetings do not have to be sunshined on an ad hoc basis. But yeah, we're getting way afar from where we need to be here, I think.
I think we're just trying to, thank you for helping us. We're trying to understand I understand it's hypothetical, but it appears to be it's going to be a new reality for us if indeed we're dissolved and then reconvened and it's the same people. We're just trying to anticipate, what our responsibilities are. So thank you for helping us.
Sure.
And the additional point I'd like to make to the group is just that when we first apparently got this responsibility, I think we all lived through it. It took us a little while to get our sea legs and figure it out. And it's certainly more efficient now. But we were in a position at the time where we had the luxury of time to figure it out. And so where we are going to be now, granted, we're functional as a group now more if it's even the same faces. But my point in that is that we have a head start in figuring it out, but we don't have the same circumstances that we had several months ago. We're in a much different situation right now. And in an organization, anytime you have a transition of leadership and a transition of decision-making, and you do that at a very critical point in time, you want that to be as smooth as possible. So although these may be some hypotheticals, if this has the potential to happen, the more we've thought through it ahead of time, the better off we're going to be if it indeed occurs. That's the point I'm trying to make.
I agree.
Just a quick comment. I guess there's only a few of us that were around before, I guess, last year this time. And so I think just historically, so the few years that I was on the board before having to deal with all the COVID, we honestly, we acted as an advisory board, and we would vote on things just like we do now. And so I don't see it as being any different than what we're doing right now, other than Dr. Buchanan wouldn't vote with us. I think that we would probably vote to make recommendations. So tonight we would have voted, 8-1, whatever. And then she would have made the final decision based on that if County Commission does decide to change us to an advisory board, just because I think that's how we'd acted for many years without realizing that we were supposed to be doing other things.
I think these have been good points of discussion. Any other discussion along those lines or any other business to come before the board this evening? Things to think about, and maybe Mr. Sanders, if you can, in your limited spare time that you might have, see if there's some more legal information that we need as we approach this possible transition.
Sure. And if I can simply ask all of you all, if you have what are going to be complex legal questions, please feel free to send them to me ahead of time, so that I'm not quite so much shooting from the hip here in your meetings. But of course, pending the outcome of the next county commission meeting, I'll be ready to work with you in whatever capacity you exist at that point.
We really appreciate that. Any other business in the other business section, or any other business at all to come before our group this evening? If not, we'll entertain a motion for adjournment, and really appreciate everybody's thoughtful input this evening. We had a lot to go over. So if it's
I'll
okay,
motion.
make the motion.
Second.
And say, y'all have a good evening. Have a safe new year.
Happy end of the year.
Yes. Very good. Thank you all. Good night.